Bienvenidos a esta nueva edición del Webinario de Educación Continua en Vía Aérea, organizado por el Programa de Anestesiología y Reanimación de la Universidad Diego Portales. El programa es dirigido por el doctor Ricardo Latrop Allende y es un programa acreditado por la Comisión Nacional de Acreditación de Especialidades Médicas de Chile. Cuenta con el patrocinio de la Sociedad Europea de Vía Aérea, la EAMS, y también del grupo FIDIVA de España. Tiene el apoyo de nuestras autoridades máximas de la facultad, la doctora Patricia Muñoz Casas del Valle, nuestra decana, y también de nuestra directora de posgrado, la doctora Alejandra Quirós, quien nos acompaña gentilmente hoy para esta sesión. También está presente el doctor Ricardo Latrop, lo estoy viendo en pantalla, quien es, como les decía, el director del programa de anestesiología y reanimación. Quiero en este momento presentarles al doctor Ashutosh Wali, Wali, anestesiólogo nacido en la India, donde realizó sus estudios médicos en el Colegio Universitario de Ciencias Médicas de Nueva Delhi. Realizó su residencia en anestesiología en el All India Institute of Medical Sciences, también de Nueva Delhi, y en el Royal Group of Hospitals de Belfast y Liverpool del Reino Unido. Posteriormente hizo un fellow en anestesia obstétrica en el Baylor College of Medicine de Houston, Texas, de Estados Unidos. Posee un doctorado en anestesiología del All India Institute of Medical Sciences. Durante su trayectoria académica ha recibido varios premios, entre los que destaca un premio del Salón de la Fama como educador ejemplar del Departamento de Anestesiología del Baylor College of Medicine, el premio de excelencia académica Fulbright y Jaworski en la categoría Docencia y Evaluación, y también es miembro de la Academia de Educadores Distinguidos, también del Baylor College of Medicine. Fue vicepresidente de la Society for Airway Management de Estados Unidos entre 2011 y 2012. Fue presidente electo entre el 2012 y el 2014 y llegando a ejercer la presidencia entre 2014 y 2016. Ha sido conferencista invitado en el Reino Unido, Arabia Saudita, México, Canadá, India, Brasil, Argentina y también en Chile, ocasión en que tuve el agrado de recibirlo. Junto con varios artículos publicados y capítulos de libros, el Dr. Wali ha aportado de manera significativa al conocimiento y a la docencia en los principales aspectos del manejo de la vía obstétrica. Por tanto, es para nosotros motivo de mucha satisfacción poder contar con su presencia en nuestro webinario, en el cual nos hablará de su visión sobre este importante tema. Demos entonces la bienvenida al Dr. Ashutosh Wali. Muchas gracias, Ashutosh. No sé si la doctora, perdón, antes de ofrecerle la palabra al doctor Wali, no sé si la doctora Quirós quisiera decir algunas palabras, puesto que esta es la primera.
Ok, hola, muy buenos días. Muchas gracias por la invitación. Yo solamente dar en nombre de la Universidad Diego Portales el agradecimiento por el esfuerzo que hace este programa, por expandir el conocimiento de sus residentes y de otros anestesistas también en temas tan importantes como es este manejo de la vía aérea. En ampliar el conocimiento trayendo y miradas, conocimiento y las miradas también, que son muy importantes, invitando a personas que se han dedicado por tanto tiempo a profundizar en estos temas. Yo solamente agradecer en nombre de la universidad y bueno, ustedes saben que cuentan con todo nuestro apoyo para lo que necesiten realizar. Espero que sea de mucha utilidad el webinario que está comenzando.
Muchísimas gracias, doctora Quirós. Si el doctor Ricardo Latrop quisiera decir algunas palabras.
Sí, muchas gracias, Ricardo. Saludar al doctor Wali, darle las gracias en nombre de la universidad y de la Facultad de Medicina, de la Dirección de Posgrado, como decía la doctora Quirós, y por supuesto del programa de anestesiología de nuestra universidad. Creo que el tema que va a abordar el doctor Wali es un tema tremendamente relevante, manejo de la vía aérea en obstetricia, y el doctor es un experto reconocido mundialmente en estas circunstancias. Por lo tanto, creemos que al tratar una paciente obstétrica en sus diferentes situaciones y muchas veces en situaciones de riesgo, creemos que es tremendamente relevante para nuestro presidente y para todos los anestesistas que asistan a este webinario, tener la visión y el conocimiento del doctor Wali para nuestro crecimiento académico. Así que, doctor Wali, muchísimas gracias nuevamente y le agradecemos que haya tenido el tiempo y la gentileza de ayudarnos en la formación de nuevos anestesiólogos. Muchísimas gracias. Gracias, doctora Quiroz, por asistir. Y, por supuesto, gracias, Ricardo, y todo el equipo que, evidentemente, hace posible que llevemos ya más de 3 años haciendo este webinario sin detención. Muchas gracias a todos.
Gracias, doctor Latrop. Doctor Wali, que tienes la palabra. Quizás quisieras compartir la pantalla.
Yeah. Do you see it?
No.
Oh, no. Okay. What happened? Share. Do you see it?
Muy sí, ahí sí.
Okay. Okay. Do you see it now?
Sí.
You see it? Okay. Hello, everybody. Thank you, Ricardo, for your very kind words and introduction. And thank you to the organizers and Ricardo for inviting me to do this talk. So my lecture is on airway management in obstetrics. However, in between, I have added some material which is relevant even in the general population, general adult population. For this presentation, I have no conflict of interest as part of my disclosure. So the first question that comes to mind is, why do this lecture? What is the reason people want to know about airway management in obstetrics? And then the other issue is, what is the incidence of the problem? Should we wait for people to respond, or should I proceed?
Proceder.
Okay. So what are our concerns? What is the incidence of the issue? So if you look at this paper from 2009, it was published in Anesthesiology, looking at liability associated with obstetric anesthesia as part of the closed claims analysis. And they found that the most common anesthesia-related causes of maternal death in the mother, and or permanent brain damage in the mother in this closed claim analysis was associated with general anesthesia. So most common issue was with general anesthesia, especially if it was complicated by a difficult airway. Few years later, in 2014, the Society for Obstetric Anesthesia and Perinatology came out with a SCORE registry from US hospitals. SCORE stands for Serious Complications Related to Obstetric Anesthesia. And they found 1 in 533 general anesthetics resulted in failed intubation. There were no deaths reported, there was no pulmonary aspiration reported, and there was no hypoxic cardiac arrest reported. But there were 1 in 533 failed intubations. A year later, in 2015, there was an article by Kinsella from UK, and they were looking again at failed intubations during general anesthesia for obstetrics. In their study, they found 1 in 443. So kind of very similar, 1 in 500 something in US data, 1 in 400 in the UK data. So here, 1 in 443 general anesthetics for cesarean delivery resulted in failed intubation. But what they also noted is that the incidence of failed intubation in OB, in obstetrics, has kind of remained unchanged in the last 40 years. From their data, they were able to find that maternal mortality or death was 1 in 90 of those failed intubations. And this was during general anesthesia for cesarean delivery. They were related either to pulmonary aspiration or hypoxemia. Amongst these patients, 1 in 60 failed intubations received front of neck access. So some kind of access in the neck, like a cricothyroidotomy. So what are the recommendations for the general anesthesia use in cesarean delivery by different organizations? Here in the United States, the Society for Obstetric Anesthesia and Perinatology has established centers of excellence in various academic institutions, and they, as a requirement, want general anesthesia for cesarean delivery should be less than 5% in the institution that is applying for Center of Excellence. In the United Kingdom, the Royal College of Anesthetists also thinks general anesthesia rate should be less than 5%, but for emergency cesarean delivery. Whereas for elective cesarean delivery, it should be less than 1%. What is the current role of general anesthesia for cesarean delivery? As you are probably aware, general anesthesia for cesarean delivery has declined over the last few decades. And this is mainly due to our understanding that neuraxial anesthesia, epidural anesthesia, spinal anesthesia, combined spinal epidural anesthesia are safer than general anesthesia, and they can be provided in urgent situations as well, especially a spinal anesthetic. What is also important to understand is that even though in the last 30 years we have made rapid advances in advanced airway management, especially with the use of supraglottic airways, video laryngoscopy, high flow nasal oxygen, the anesthesia related complications of general anesthesia for cesarean delivery are still high. And there are other issues like surgical site infection, venous thromboembolism, postoperative pain in the mother, and postpartum depression. This is more incidence related data, but a recent paper and is important. What is the frequency and risk factors for difficult intubation in women undergoing general anesthesia for cesarean delivery? This is a United States multicentric data, 15,000 intubations between 2009 and 2014, and they found the incidence of difficult intubation close to 1 in 50, 1 in 49 in this paper. And the risk factors, not surprisingly, were patients with higher BMI, Mallampati score of 3 or 4, meaning mouth opening is not that great, limited jaw protrusion, limited hyomental distance, and limited neck range of motion. So about 1 in 50 were difficult intubations. But what about failed intubation? Failed intubation obviously was lower, 1 in 800. And the lower incidence of these failed intubations has been noted from the previous years. So we have made some progress. And it's partly related to the greater use of neuraxial anesthesia. And whenever intubations failed, supraglottic airways were used in their rescue. So for my lecture, I've divided it into these subheadings. I'll talk about general anesthesia for obstetrics, the lack of training that we now have in general anesthesia, time of the day the surgery occurs. What about airway assessment? How do we pre-oxygenate patients? How do we position patients? How should we do rapid sequence, role of cricoid pressure, tracheal intubation difficulty, failure of tracheal intubation, failure of oxygenation, critical airway, and issues with extubation. So general anesthesia and obstetrics. So the first question, is it risky? General anesthesia in the obstetric airway is anatomically difficult and physiologically difficult. And some of the reasons are listed on the slide. There is airway edema, just from swelling, which is a hormonal change and gets worse with preeclampsia. It also gets worse with prolonged labor, protracted labor. Functional residual capacity is reduced because of the splinting of the diaphragm from the gravid uterus pushing the diaphragm up into the thorax. There is increased oxygen consumption, which increases by about 20%. And this is increased consumption both by the fetus and the placenta. Also to note, the functional residual capacity reduces by about 20%. So the number to remember is 20. FRC goes down by 20. Oxygen consumption goes up by 20. There is weight gain associated with pregnancy. There is enlargement of the breast, so it is difficult to place a laryngoscope blade in the mouth. So a trick is to use a short handle laryngoscope blade, or to use the blade, insert the blade first, then connect the handle to the blade. There is hormonal and mechanical changes which lead to lower esophageal sphincter tone being reduced, so that the barrier pressure across the lower esophageal sphincter is lowered, and therefore reflux is very common in pregnant patients. If patients go into labor, gastric emptying is delayed, and supine position because of lower FRC, higher oxygen consumption, aortocaval compression, all makes the obstetric airway not only anatomically difficult, but physiologically difficult. What about lack of training? Now that we have realized general anesthesia for cesarean delivery is risky, we are doing more and more cesarean sections under spinal anesthesia or combined spinal epidural anesthesia or epidural anesthesia. So our trainees, residents, are not getting enough experience in general anesthesia for cesarean delivery. Additionally, in the United States and many parts of the world, the working hours have been reduced for trainees, so their exposure is further compromised. So as a nutshell, the trainees have fewer opportunities to encounter the obstetric airway for general anesthesia and the difficulty that comes with the obstetric airway for general anesthesia for cesarean delivery. So in the non-obstetric ORs, operating rooms, we are now more and more going away from tracheal intubation to use of supraglottic airways. So even the intubation skills, you can say, of our current trainees are not as good as they were, let's say, 40 years ago. And it is partly because of the revolution of supraglottic airways. So when trainees come to the labor and delivery unit, their airway skills for intubation may be compromised. And this is a concern that was voiced about 15 years ago. However, things have changed in the last 15 years. We have more experience with video laryngoscopy, and that, as you will see in the presentation, I will talk about it. The other issue is time of the day, when the cesarean section is going to take place. Majority of them for general anesthesia are emergencies, whether it is for cord prolapse, whether it is for maternal hemorrhage, whether it is for eclampsia leading to an emergency delivery. Often this is during late hours in the night or during weekends. There may not be enough staffing available. The anesthesia providers may be inexperienced, especially in some parts of the world, and they overall may not have good proficiency in advanced airway management. The National Audit Project number 4 from United Kingdom that was published in 2011 said one of the main causes of complications for overall airway management in UK, not necessarily OB, but overall complications, was poor airway assessment. The ASA difficult airway guidelines from the past, like 2013, had a table which showed the components of the pre-op airway physical examination. And if you notice, the top 5 of these components were related to really the mouth opening: length of upper incisors, relationship of the upper jaw and the lower jaw during normal closure, relationship of the upper and lower jaw during voluntary protrusion of mandible or the upper lip bite test, interincisor distance and visibility of uvula, everything to do with the mouth. And then if you look at the bottom 6, it's a lot to do with the neck, shape of the palate, compliance of the mandibular space. Is there a lot of fatty tissue there, or redundant tissue, thyromental distance, length of neck, thickness of neck, and range of motion of head and neck. So neck and mouth exam is very critical. That was for the general population and relates to OB. And then there was a paper about 30 years ago from South Africa, Tony Rock's group, looking at relative risk analysis of factors associated with difficult intubation and obstetric anesthesia. And what they said was, if somebody has Mallampati 1 mouth opening, short neck, receding mandible, and protruding incisors, the probability of difficult intubation is about 53%. And as the Mallampati score increases, the probability of difficulty in intubation in OB, general anesthesia, obstetric general anesthesia, is about above 90%. So what should you do as part of your airway assessment? As soon as the patient comes to the labor and delivery floor in our hospital, as soon as they're admitted, we get notified and we do a physical exam, including a detailed airway exam, especially in patients where we are concerned, somebody who is morbidly obese, somebody who has preeclampsia, prolonged labor, and so on. We also have multidisciplinary rounds on our labor and delivery floor near the main board. We have multidisciplinary rounds both at 8 a.m. and 8 p.m. daily. These are led by the obstetric attending or consultant, and part of the rounds, the people that are represented in the group are from obstetrics, anesthesiology. In our case, it is really a dedicated group of obstetric anesthesiology, neonatology, family practice, midwifery, nursing, from labor and delivery, from the obstetric floor, from neonatal ICU, newborn area, and respiratory therapy. Everybody introduces themselves. The OB consultant attending goes over the entire board. Everybody gives their opinion about any anticipated problems. People get an opportunity to ask questions and voice their concerns. And finally, we go over our routine safety phrases at the end. So, as our understanding of the risk of general anesthesia for obstetrics has increased over the years, there has been a great role of neuraxial anesthesia, and there has been a lot of acceptance of neuraxial anesthesia. So typically in our situation, let's say an emergency cesarean section is called by the obstetric team. We go to the operating room, we always check the fetal heart tones again, then communicate with the obstetric team to make sure how important it is to proceed with general anesthesia, because they also understand general anesthesia can be risky. So if the baby is doing well, fetal heart tones are reasonable, we will sit up the patient and do a spinal anesthetic or a combined spinal anesthetic, combined spinal epidural anesthetic. It avoids the need for general anesthesia and airway manipulation. We also encourage early epidural placement in the labor and delivery area for the same reason that in an emergency we don't have to proceed with general anesthesia. Sometimes labor analgesia from the labor and delivery area may be needed to convert to surgical anesthesia for a cesarean section. But it may not always be successful because of time, because of improper placement of the catheter or migration of the catheter. And in these studies, failure rate was seen to be as high as 8%. In 2012, there was a meta-analysis which demonstrated the need for conversion to general anesthesia in 5% of women who received epidural analgesia in labor. So even though we have now realized neuraxial anesthesia is safe, there are certain times when general anesthesia may be required, right? It could be a stat situation. Neuraxial anesthesia is contraindicated. Platelet count may be 30,000. Patient refuses, even though we try to talk to them, reassure them, make them understand, educate them about the safety of neuraxial versus general. Or one may fail to place a neuraxial, or one may fail to provide adequate anesthesia following neuraxial anesthesia. So in that situation, depending on the airway and the urgency of the cesarean section, you may think of doing an awake intubation. But if everything looks reasonable, airway assessment is okay, you may proceed with induction of general anesthesia. If awake intubation is needed, and these are, again, as I said in the beginning of my lecture, this is not only for obstetric patients, even though my focus is on obstetric patients today, but these are tips that can be used in the non-obstetric general adult population as well. So for awake intubation, it can be done with a fiber optic bronchoscope. It can be done with a video laryngoscope. Of course, it needs good topical anesthesia. Direct laryngoscopy has been used, though not ideal. Supraglottic airways have been used for awake intubation, and then awake intubation through the supraglottic airway. Optical stylets and light wands have been described. Some of the tips for awake intubation: you have to talk to the patient, communicate to them, reassure them, give them gastrointestinal prophylaxis with a non-particulate antacid, H2 blocker, and a gastrokinetic drug like metoclopramide. The non-particulate antacid neutralizes any stomach acid that is present. The H2 blocker reduces the secretion of further acid, and a gastrokinetic drug like metoclopramide helps with passage of stomach contents into the intestine. In addition, to make especially fiber optic bronchoscopy easier, it is nice to have a dry mouth without too many secretions. For that reason, I like to use an anti-sialagogue like glycopyrrolate. because we have decided this patient may be difficult, it is wise to use minimal sedation, um, a lot use a lot of topical anesthesia. I use 4% lidocaine mainly with a magic atomizer. You want to avoid the nose in the pregnant patient because it's very hyperemic and fragile and it may bleed with the passage of a tube through the nose. So we do oral intubation preferably. And in the last 10 years or so, we have had the luxury of high flow nasal cannula oxygen. I use the Sago technique using topical anesthesia with a magic atomizer. And when the cords come into view, vocal cords come into view with a fiber optic bronchoscope, I inject 4% lidocaine through the bronchoscope, both above the cords and through the cords into the trachea. If there is concern about gastric reflux, the patient should be able to protect themselves because they are still awake. We can see it and aspirate it via the bronchoscope. Key to minimizing risk for pulmonary aspiration, which is a concern in obstetric patients, is use of GI prophylaxis to prevent pulmonary aspiration, avoid oversedation, and monitor for reflux or emesis. There's a study done by Dr. Ovasapian in non-obstetric patients a long time ago, 30 years ago. And there were 129 patients who received a translaryngeal block through the neck where they injected medicine. And they found that topical anesthesia of larynx does not impair voluntary motor function of the vocal cords, such as coughing on request, thus allowing a protected airway. The key is to have the patient awake. So both translaryngeal and Sago techniques are effective and safe with no evidence of regurgitation or aspiration based on these studies. Another good tip for fiber optic bronchoscopic intubation is the use of the endotracheal tube. So the usual tracheal tubes come with a bevel which is pointing to the left. If you place the tube erect, the bevel points to the left. So what happens is when you have passed the bronchoscope into the vocal cord, through the vocal cords into the trachea, the bevel, which is in the normal endotracheal tube, can hit the right arytenoid. And that sometimes causes hanging up of the endotracheal tube at the level of the vocal cords. To avoid it, you can use a special tube which has a ski tip. It's more like a ski that you use on the ice slopes. It hugs the bronchoscope. It doesn't go away from the bronchoscope like the regular tube. And because it hugs the bronchoscope, it is easier to pass it over the bronchoscope through the cords into the trachea. This is a general tip for any fiber optic bronchoscopy. And there are many kinds of ski tipped tubes available. It doesn't have to be a Parker tube. The other issue in pregnant patients is airway edema, and this develops gradually as pregnancy advances. However, acute changes are known to occur during labor, especially in prolonged labor. And then it can also worsen in patients who have preeclampsia. Expulsive efforts during second stage of labor may further compromise the airway because of greater edema. And then it is important to realize that you may have seen your patient in labor, let's say 12 hours prior, and now 12 hours later, they are requiring general anesthesia for cesarean delivery. Your airway assessment of the Mallampati score and the other parameters may be different and may have changed over the last 12 hours, depending on how protracted, how difficult the labor course has been. So it's important to reevaluate the obstetric patient's airway immediately before induction of general anesthesia, rather than rely on an assessment that was done before labor or during early labor. If you do proceed with general anesthesia for cesarean delivery with an endotracheal tube, then before extubation, also remember to evaluate for an air leak before you extubate the patient, especially in patients who have received a lot of fluids, a lot of blood products for massive postpartum hemorrhage. Another good study done now 50 years ago. It's just amazing. This study was done 50 years ago by Dr. Gertie Marks. Dr. Marks is known as the mother of obstetric anesthesia in the United States. She is the person who made people realize that the obstetric airway was difficult and different from the non-obstetric patients. So this was a study comparing gynecology patients with pregnant patients. And what they did was they pre-oxygenated both groups of patients with standard pre-oxygenation. This was 1974. And what they found was that after adequate pre-oxygenation for 3 minutes or more, the starting PaO2 in the non-pregnant patients was around 500. Then they induced these patients and used a muscle relaxant like succinylcholine. They provided apnea for 1 minute because that was the standard of care back then, for rapid sequence induction. And they found that the PaO2 fell from 500 to about 450 in the non-pregnant patients. So there was a decline in the PaO2, but it was not too much. And these were patients with normal BMI. Then you come to normal BMI pregnant patients. After pre-oxygenation for more than 3 minutes, their starting PaO2 was about 475, 473. But after 1 minute of apnea, such as mimicking succinylcholine use and not ventilating during that period, the oxygen PaO2 dropped from 475 to 334. So the decline in PaO2 was steep in the pregnant patient. And that is because, like we said earlier, their functional residual capacity is lower by 20% and their oxygen consumption is higher by 20%. So how should we pre-oxygenate patients? The goal of pre-oxygenation is denitrogenation. And there have been different techniques described, but the best thing to remember is monitoring the expired fractional oxygen concentration. If you can start with a concentration of FeTO2 above 90, that's your best marker of lung denitrogenation. There are various techniques described. The 3-minute technique with either 8 deep breaths over 1 minute or 4 deep breaths over 30 seconds. And in this paper, the 8 deep breaths per minute for 3 minutes for emergency obstetric anesthesia was the better technique. Pre-oxygenation considerations, it may be inadequate due to air entrainment, so a tight-fitting mask is important. 90-degree FeTO2 or higher is better. I raise my patient slightly head up tilt and keep them on a ramp if needed. It delays the time to desaturation, especially in the obese patients. Now we have high flow nasal oxygen, and I use it a lot for the morbidly obese patients or the severe preeclamptics. It works by diffusion and fills up the pharynx with high levels of FiO2 due to the decreased oxygen demand during apnea. It also increases safe apnea duration. We can use it during tracheal intubation attempts. It can be a regular nasal cannula or it can be a high flow nasal cannula, depending on your requirement and availability of equipment. It can be used during awake intubation for oxygenation throughout the process. And we have been very fortunate to have it in our obstetric operating room and then in the non-obstetric area in the main operating rooms, in out of OR remote areas like the GI lab, and so on. We have these dedicated high flow nasal oxygen cannula devices called OptiFlow in all the areas of the hospital. Positioning is very important. The ramped position is important for it allows for keeping the patient's head elevated, and the goal is to have the sternal notch at the level of the external auditory meatus. So the external auditory meatus, the tragus, should be at the level of the sternal notch. So that is your ideal position, not only for pre-oxygenation, but also for intubation, face mask ventilation, for supraglottic airway placement, for extubation, and if needed, to have front of neck access, such as cricothyroidotomy. So I cannot emphasize enough the importance of head elevated laryngoscopy position. And a lot of this work was done by Rich Levitan. What about rapid sequence induction? It's always a requirement concern during situations where intubation is urgent. The goal is to minimize risk for aspiration so that you can quickly intubate the patient. It's the standard for obstetric general anesthesia. The usual practice is to avoid ventilation after the administration of succinyl choline. So a patient gets propofol, succinyl choline, wait 1 minute or so till the endotracheal tube is secured. The risk of this technique, we know now, especially as our population is getting more obese. A lot of our patients are morbidly obese, BMI above 40. It may increase the likelihood of failure because we have had a period of apnea for 1 minute or more, and patients may not be in an emergency adequately pre-oxygenated. And then if for any reason you have difficulty in intubation or failed intubation, then they can get hypoxia. So what I do in my practice, and it has also, I've been doing it for many years, about 12, 13 years now, but was more recently published in the Obstetric Anesthesia Guidelines in 2015 by Difficult Airway Society, was to use minimal positive pressure ventilation during that period of apnea after administration of succinyl choline before putting the endotracheal tube in, to minimize hypoxia. And the concern is that you may accidentally fill up the stomach with air and therefore cause regurgitation and aspiration. The way I do it is use very low pressures, 10 to 15 centimeter water, and if needed, also put in an oral airway to facilitate this process. So gentle mask ventilation is the way to go, and it prolongs the time to desaturation and tells you early on about the ease of ventilation. This concern that we've had for 50, 60 years about the use of bag mask ventilation between induction of anesthesia and intubation does not have any evidence to support its use. So that practice is not really based on evidence. The other consideration, so bag mask ventilation during rapid sequence, following induction drugs before intubation, is something to incorporate in your technique. The other concern is about the use and validity of cricoid pressure. Cricoid pressure were described by Selig in around 1961, and the goal was to decrease pulmonary aspiration during induction of anesthesia. This was the interest was promoted by reported deaths due to aspiration under general anesthesia prior to that time. But more recently, it has been questioned Do people know where to apply cricoid pressure? Is it applied correctly? Is enough force used to apply cricoid pressure? The recommended was 40 newtons, which is very high force. Is it really efficacious when applied properly? And then finally, if laryngoscopy is becoming difficult during regular intubation, during rapid sequence intubation, it may be necessary, I think this is important, to transiently release cricoid pressure, get the larynx into view, intubate the patient, then maybe put cricoid pressure back on till you confirm placement of the endotracheal tube with capnography. Another consideration, again from the general population, which can be extrapolated to our OB population, is how many attempts. Repeated intubation attempts have been shown as a major complication of airway management, both in United Kingdom, in the NAP4 study, and in the United States. NAP4 data showed that 68% of devices involved in major reported complications were the use of tracheal tubes. And incidents related to these were failure, difficulty, delay, or cannot intubate, cannot ventilate situation. Here, one of my colleagues and friends from Society for Airway Management, Tom Mort, did a study looking at sorry. Can you see me? Can you see the slides? Oh, sorry. Yes. So Tom Mort did a study looking at emergency tracheal intubations and associated complications. And interestingly, what he found was less than 2 attempts, complications were lower in the entire group, whether it was hypoxemia, esophageal intubation, severe hypoxemia, regurgitation, and so on. But if attempts were more than 2, if tracheal intubation attempts were more than 2, the incidence of hypoxemia, esophageal intubation, and the other complications was very high. And the relative risk was also very high, understandably, for greater than 2 attempts. Oh, what happened? Okay. So he said it is very critical to limit intubation attempts and you should look for something else, do something different. And in between attempts, I cannot emphasize enough, this is the most important part of, I think, my slide, whether it is for obstetric patients or non-obstetric patients. In between attempts, it is very critical to attempt reoxygenation. You may have to keep the patient asleep, or you may decide to wake up the patient. But if you decide to proceed with general anesthesia, reoxygenation is very important. Okay, so going back to the Difficult Airway Society guidelines from 2015, they said issues that make OB general anesthesia difficult for cesarean delivery is, again, the anatomic changes, physiologic changes, presence of the fetus, and having a plan for failed intubation and failed oxygenation. So in their master algorithm for obstetric general anesthesia, they said it's important to have a pre-induction plan and prepare and have a team discussion with your anesthesia team, OB team, anybody else who is important. Let's say in some institutions, there are respiratory therapists who come and help. And then during rapid sequence induction, consider face mask ventilation. So pre-oxygenation with high flow if possible, or highest possible flow. Face mask ventilation during rapid sequence induction. Use of video laryngoscopy if you have it available. It improves first chance, first pass success rates. If you do not have video laryngoscopy, then make sure intubation attempts are only 2. If you succeed, very good. You can proceed with surgery. If not, then you have to reevaluate. So important here, they said 2 attempts plus 1 for maybe a senior experienced person with better skills. This is for OB. For general adult population, they have said, and that's for the non-obstetric group, is 3 attempts plus 1 for the skilled person. So video laryngoscopy has been available now for 10-15 years in different parts of the world. There are 2 major categories, non-channeled and channeled. And then more recently, they have been described as standard geometry, regular video laryngoscopes, or the hyperangulated video laryngoscopes. The standard geometry scopes, video laryngoscopes, allow for direct laryngoscopy and indirect, hyperangulated only indirect visualization. For standard geometry, you need increased requirement for head and neck manipulation. Hyperangulated, you don't need as much manipulation. First pass success is 90% or higher with standard geometry, 80% with hyperangulated. Standard geometry allows use of a bougie. This, you have to use a rigid stylet that conforms to the curvature of the blade, and it's preformed. What about video laryngoscopy in obstetrics? 180 intubations, 3-year period. This was a study done by Mike Aziz and his group. They looked at direct laryngoscopy and video laryngoscopy. They used direct laryngoscopy in 157 out of 163 patients, first attempt. 5 patients required more than 1 attempt. They failed once and rescued with video laryngoscopy. They did video laryngoscopy in 18 of 18 patients, first attempt. There were predictors of difficult direct laryngoscopy in 16 of those 18 patients. All these patients required urgent or emergency surgery, and they said that video laryngoscopy is a useful adjunct for obstetric airway management. Another paper, observational series of 27 patients, rapid sequence induction followed by direct laryngoscopy using a CMAC blade, which is a standard geometry blade, and intubation using video laryngoscopy with CMAC again. And the laryngoscopic view was graded between DL and VL. Better grades were observed with VL, with 100% successful intubations with VL. And this is a table from the same group showing the same information. And they said video laryngoscopy presents a better view. However, as you may have noticed who use video laryngoscopy, sometimes or majority of the time during video laryngoscopy, the larynx is easily visible. The problem is delivery of the tube. So you can see the larynx, but you cannot pass the tube. And what is the reason for that? The usual reason is that you have this kind of view, meaning the tip of your blade is very close to the vocal cords. So there is something which has been described by George Kovacs. So this is the same view as the view on the top here, meaning the tip of the blade is very close to the vocal cords. And he said you can actually sometimes see the cricoid ring. So it's been called the Kovacs sign. So what is the treatment? The treatment is to pull back, withdraw the tip of the laryngoscope blade, place it in the vallecula, expose the epiglottis, and have this kind of view where you see the bottom 2/3 of the vocal cords. You don't need to see 100% of vocal cords for passage, easy passage of the tube. So this is that view that you need. The tip of the video laryngoscope blade should be in the vallecula, and that allows for easier passage of the tube because you can see the tip of the tube advance through the hypopharynx as you pass it into the vocal cords and the trachea. So a small detail, but it helps, I think, with many difficult situations. So if intubation fails, then obviously you should announce it in the operating room, let everybody know, let the obstetricians know, because now everybody's goal is you cannot proceed with surgery. Your goal is to provide oxygen. So how can you rescue it? You can do it with a face mask, 2% technique, 1% technique, oral airway, use of strap under the head, or you can use a supraglottic airway. It may be important to release cracked pressure at this time if placement of supraglottic airway is being difficult. So that may be a transient release of cracked pressure. If oxygenation is adequate, you can proceed with surgery or wake up the patient depending on how your clinical situation is. So discussion with the obstetric team is very critical every few um, seconds, or if not if every few minutes, if not every few seconds. So if intubation fails, we said you can use a supraglottic airway, and now there are many supraglottic airways. So preferably a second generation supraglottic airway where you can pass an orogastric tube through the secondary port to remove some of the stomach contents, if not all. First, the 2% mask ventilation can be done with 2 hands by the same person and somebody else helps, or you can put your ventilator on a pressure controlled ventilation mode, less than 15 centimeter water, or the first person holds the bag and mask and second person applies jaw thrust and chin lift. Some of the adjuncts that are available include oropharyngeal airway, strap that goes around the patient's head and mask, but avoid the nasal airway because of the tendency for pregnant patients to bleed easily. If all is well, you can proceed with this supraglottic airway, and you can actually intubate through the supraglottic airway using a fiber scope. Either directly intubate over the fiber scope or intubate over an airway exchange catheter. There are issues with using the airway exchange catheter in the OB patient because you have an unprotected airway when you remove the bronchoscope and the supraglottic airway. So we can talk about it later. All right. So in 2022, the American Society of Anesthesiologists revised their airway guidelines, and I basically took that slide from the guidelines, trying to show that what they are recommending now. So if you are able to ventilate the patient, let's say with a supraglottic airway, then you are on the non-emergency pathway. So the thing to decide at this time is, should we wake up the patient? Should we use the supraglottic airway and continue? Or do we need to go invasive airway for any reason? So if you are non-emergency pathway, invasive airway is may not be necessary. But if ventilation is not adequate, then you are on the emergency pathway and you have to establish ventilation either with a tracheal tube, continue with the supraglottic airway, and if it still is inadequate, you are in the critical airway zone over here. So for the adult population, they recommend using no more than 3+1. So 3+1 means 1 use of face mask, 1 use of supraglottic, 1 attempt with supraglottic airway, 1 attempt with tracheal tube, 1 per class, trying to provide oxygen as you can, and then 1 additional last attempt by a clinician with higher skills. So that's why they call it the 3+1 attempt. This is for the non-obstetric difficult airway guidelines. Okay, so I want to quickly go over the literature that has been available for use of supraglottic airways in pregnant patients for elective cesarean delivery. Large study by Preston, 1,000 plus patients, rapid sequence induction, cracked pressure, used classic LMA. They said 99% patients effective airway and 98% was first attempt. Another large study, ProSeal LMA for routine cesarean delivery, 3,000 patients. They're fasting for 8 hours. Propofol and rocuronium was used, not succinylcholine. They used ProSeal LMA, successful establishment on first attempt in 99.7%. No aspiration, none required intubation. One patient had regurgitation and spillage of gastric contents into the mouth. This was published in 2010 in Anesthesia Intensive Care. LMA Supreme for cesarean delivery. So LMA ProSeal is reusable. LMA Supreme is disposable. Single-use second generation supraglottic airway was used in both elective and emergency C-section. This was a paper from 2012. 700 patients, one attempt, 98%. Time to effective airway, less than 20 seconds. No reports of pulmonary aspiration. And then the latest kid on the block, which is the iGel for elective cesarean section, 1,000 patients, fasting for 8 hours or more, elective cesarean delivery, BMI was less than 30, pre-oxygenated for 3 minutes, propofol, rocuronium, gentle ventilation till they established paralysis, and then used an iGel size 4 or 5 weight-based. And first attempt was reported in 99% of patients. Time to successful insertion, less than 15 seconds. No failure of insertion. Peak airway pressures were low. No regurgitation, aspiration. Minimal sore throat. Obstetrician was happy. Patients recovered fast. So in conclusion, they said iGel is a useful second generation supraglottic airway for elective cesarean delivery in low BMI patients. And it can replace tracheal intubation for elective cesarean delivery. But the question really to ask is, do elective cesarean delivery patients need general anesthesia in the first place? Laryngeal mask airway for cesarean delivery in the Chinese Medical Journal, 2017, 192 cases over 5 years. Major indication was failed neuraxial block or contraindication to neuraxial block. So this is a little different. They used LMA Supreme in 30%, intubated in 70%. Emergency delivery rates for the two groups are described, no regurgitation or aspiration. And they said that second generation LMA is useful for obstetric anesthesia based on their 37%, 36% use. Another technique that has been described is the use of the laryngeal tube. I know Ricardo had used combi tube many years ago for 2 cases, I think, and he may attest to it a little later. I don't have that slide with me in this presentation. So what happens after you put in a second generation supraglottic airway? What are the next steps? This is very important. So you had difficulty intubating, you rescued with a supraglottic airway. Now what? Most important, communicate with the obstetrician. Aspirate any stomach contents. Use pressure controlled ventilation less than 15 centimeter water. It allows you to keep your hands free, but you can do manually. Tell them to proceed with the cesarean section and ask them if they can avoid exteriorization of the uterus, meaning removal of the uterus outside the pelvic cavity on the patient's abdomen to deliver the baby. Second, avoiding fundal pressure during delivery, even if you didn't exteriorize the uterus. Proceed with delivery of baby, and then we can decide whether we want to use the supraglottic airway to finish the case, or do we need to fiber optically put in a tracheal tube through the supraglottic airway. Again, airway exchange catheter can be used. The question is, should that be the technique? So if all this is good, that's fine. But if you cannot oxygenate your patient with the supraglottic airway, you may have to perform front of neck exposure, such as a cricothyroidotomy. Because cricothyroidotomy is not practiced a lot, it's not used a lot, the failure rate is high, and this was in the NAP4 study from 2011. And again, cricothyroidotomy has a role. here, emergency invasive airway. That's the ASA latest guideline. This was a paper from 2011. This paper is from Brigham and Women's Hospital in Boston. 98 patients required general anesthesia and obstetrics over this period. One sentinel event was reported with a patient with class 3 airway. 3 intubation attempts were done. They were all unsuccessful. They used an LMA to rescue. There was severe laryngospasm. Probably patient was not anesthetized well. They ended up in a cannot intubate, cannot oxygenate situation. Attempted cricothyroidotomy. It was successful. It was done within 5 minutes of induction. Patient was decannulated 5 days later. Had a DL done electively to see. At that time, 5 days later, the airway was class 1. So we talked so far about intubation, but extubation and emergence are an issue as well. Again, from the NAP4 data, the Cantwell data, that hypoventilation and airway obstruction for patients waking up after general anesthesia for cesarean delivery have been recently recognized as causes of maternal mortality. This was a paper by Jill Meyer in 2007 in Michigan. 8 anesthesia-related maternal deaths occurred between 1985 and 2003. They were all, mind you, none of them was during intubation or induction. They were all during emergence from general anesthesia in the recovery period. 6 of these 8 patients were obese. System errors were identified in 5 of these patients. Patient care did not meet recognized standards. Errors included inadequate supervision by an anesthesiologist and lapses in postoperative monitoring. So extubation strategy, how should it be done? Should you do it over an airway exchange catheter, supraglottic airway, and there are other techniques. Very important after an event like this to debrief. Everybody should get together. The anesthesia team, the OB team, nursing, neonatology, anybody who is in the operating room. For us as anesthesiologists, we should write a difficult airway note in the electronic medical record, communicate with the family of the patient, communicate with the patient when they're fully awake, inform risk management, and try to use this as a means of quality improvement for future. So how should you proceed? Plan your airway properly in advance, practice, prepare, and perform. So in terms of patients coming to the labor and delivery floor, previous airway history is important. Current detailed airway exam, especially for patients who require general anesthesia. Repeating airway exam is important because it may have changed from when they started their labor process 18 hours ago, let's say. If you have difficulty, call for help. Have a difficult airway cart available. We in our institution have a difficult airway cart which sits outside the obstetric operating room area, and then have equipment for supraglottic airways and cricothyroidotomies available in your anesthesia machine. And if you have to, perform cricothyroidotomy early. In terms of preparation, also practice on mannequins, simulators, airway, reassuring airway patients in the OR, and also make sure that any attempts that you do should not be repeated, the same attempt, but different attempts, and each attempt should be time limited. So what would you change in your practice of general anesthesia? These are my questions for the audience. What is the role of high flow nasal oxygen? Do you use it? Is it available in your OB ORs? It may be available in the regular ORs, but not in the OB ORs. We use the ramp and we have that true pillow available in the OR. Do you use the ramp? Do you use blankets instead? They work too very well. What about video laryngoscopy availability? And then finally, I want you to take these points home. The reevaluating of the airway, obstetric airway in the OR is important. Use of head elevated laryngoscopic position. Use of apneic oxygenation between the induction and intubation time during rapid sequence. If you do not use face mask ventilation, ideal is to use face mask ventilation during RSI, especially between induction and intubation. I always start with a video laryngoscope now for many years. Application of cricut pressure is debatable, but if you have to release it, release it. And if you have to suction the oral cavity, suction it. So have a suction available readily. Second generation supraglottic airways and calling for help are important, and do early cricothyroidotomy. Each step should be less than 60 seconds, even less than 45 seconds, so that you can provide oxygen in between attempts and also get a secure airway, even if it's a cricothyroidotomy, by the end of 4 minutes or so. Thank you.
Muchas gracias, doctor Wali. Realmente ha sido una exposición
Thank you.
extraordinaria acerca de este tema tan importante, tan interesante, que para quienes trabajamos en servicios de obstetricia, ya sea ocasional o permanentemente, es muy relevante para nuestra práctica poder ofrecer el mayor grado de seguridad en el manejo de la vía aérea de nuestras pacientes. Quiero en este momento transmitirles un saludo del doctor Raúl Silva Quirino, que es brasileño, que es de Brasil, que seguramente tú lo conoces, Ashu. Él nos dice: buenos días, doctor Wali, doctor Urtubia, doctor Latrop, y a todos del magnífico webinar.
Who is this?
Raúl Silva. Raúl Silva.
Oh,
Sí,
good morning.
Él envía un gran saludo porque él está en el Congreso de la EAMS en Estambul en este momento.
Oh, okay, excellent.
Envía muchos saludos. Y está allá.
Thank you.
Bueno, yo quisiera, si no hay
Greetings to you as well,
preguntas,
Dr. Silva.
quisiera darle la palabra al doctor Latrop, que también tiene una gran trayectoria en anestesia obstétrica y seguramente debe tener algunas observaciones con respecto a este tema tan relevante. Ricardo.
Bueno,
Sure.
muchas gracias, doctor Wali. Ha sido un placer conocerlo y además le reitero el agradecimiento de nuestra Facultad de Medicina, de nuestra universidad y por supuesto del programa de anestesia del departamento de la Dirección de Posgrado de la Universidad Diego Portales. La verdad es que en un proceso natural como es el parto, los anestesiólogos, si bien podemos ayudar en el tema de la conducción del parto, en el tema de la analgesia, de alguna manera nos involucramos en una situación que es natural. Y como siempre, la naturaleza es más sabia que nosotros y nosotros de alguna manera nos involucramos en un proceso que debería tener un curso natural. Ahora, el tema de la vía aérea es tan relevante, no solamente porque estamos dando anestesia a la mamá, sino que también estamos protegiendo el futuro desarrollo del cerebro fetal. Por lo tanto, el tema de la oxigenación es un tema crítico. En nuestro país, la gran mayoría de las anestesias para cesárea o de conducción son regionales. Pero cuando nos enfrentamos a una anestesia general, evidentemente el tema de la vía aérea pasa a ser un elemento crucial en el desarrollo de el bien llevar, de alguna manera, la seguridad de la madre y del feto. Por lo tanto, doctor, yo quisiera reforzar de alguna manera todas las medidas de seguridad que uno siempre tiene que tener en una anestesia obstétrica, porque además nunca sabe en qué momento va a tener que pasarse de una anestesia regional a una anestesia general. por alguna complicación intraquirúrgica, o alguna inercia uterina, o un sangramiento masivo, o etcétera. Yo, la verdad es que trabajé aproximadamente 20 años en anestesia obstétrica en hospitales públicos chilenos. Y obviamente era tremendamente estresante, de alguna manera, el tema de conservar la perfusión materna, la ventilación materna, protección del feto. Por lo tanto, creo que su charla ha sido extraordinariamente positiva, buena, aclaradora en muchas cosas. Evidentemente, escuchar a alguien con la experiencia suya es muy importante para nuestros residentes, para los médicos que estamos formando a otros colegas y, por supuesto, para ellos, en el sentido de saber, conocer experiencia de una persona con tanta experiencia como usted. Muchísimas gracias, y la verdad es que este siempre es un tema que de alguna manera los anestesistas, la parte estética, tendemos a dejar un poco olvidado. Muchas veces deja de ser atractivo en pos de otras anestesias, anestesia neuroquirúrgica, cardíaca, torácica, pero la verdad estamos involucrándonos en un tema natural y que es absolutamente indispensable para nuestra especie. Muchísimas gracias, doctor Wali.
Sure. Thank you for being in the audience, and thank you for listening. You're welcome. If you have any questions, I'm happy to take any questions.
Sí, mira, Ashu, antes de ofrecerle la palabra al doctor Raúl Silva, quiero contarles que la doctora Vilma Medina envía muchos saludos desde Tijuana, México. Y dice: buenos días, excelente información para los que trabajamos en obstetricia. Saludos desde Tijuana, México.
Greetings to you, Dr. Medina and Dr. Silva.
Muy bien. Doctor Raúl Silva, aquí está el doctor Raúl Silva, está conectado desde Estambul.
Olá, bom dia a todos, né? Bom dia, doutor
Greetings.
Wali, doutor Túbia, doutor Lantrop. Estou aqui no Congresso Europeu de Via Aérea, aqui em Istambul. E, inclusive, felicitar doutor Lantrop por ser o novo representante do Conselho Chileno da EMS, né? Parabéns, doutor. Dizer ao Dr. Wali que foi uma apresentação muito boa, né, de extrema importância, com várias estratégias, né, para mitigar possíveis catástrofes nesse público tão particular, né, da paciente obstétrica. Né? A paciente, com certeza, tem muitos, assim, mais fazendo um comentário, mas muitas alterações do ponto de vista fisiológico, de via aérea difícil também anatômica, né, com suas alterações, né, muitas vezes são situações não eletivas, né, essas abordagens e o manejo da via aérea dessas pacientes, né, como o Dr. Lantrop falou, existe esse binômio mãe e filho, né, o que causa mais estresse situacional, né, do time todo, né, e potencial catastrófico em relação à broncoaspiração e hipoxemia grave, né? E muitas vezes, né, no hospital que eu trabalho, inclusive, que eu sou do Brasil, no hospital que eu trabalho, é bem distante o centro obstétrico do centro cirúrgico. Então, às vezes, não temos os mesmos recursos, né, tanto de recurso humano quanto de recurso material no centro obstétrico como no centro cirúrgico, né? E perfil das pacientes, né, cada dia com um IMC maior, né, que juntamente todas essas situações combinados, né, vão influenciar nessa dificuldade do manejo da via aérea dessas pacientes. Então, foi ótima a palestra, parabéns, doutor Wali, mais uma vez, e um grande abraço a todos vocês aí.
Muchas gracias, Raúl. Felicitaciones también por tu cometido en Estambul, en la EMS. Sé que tú eres el nuevo representante de Brasil ante la EMS Así que muchas felicitaciones para ti y un gran abrazo. Eh, Antes de terminar, yo tengo un par de preguntas, Achu, que a mí personalmente me han angustiado siempre y creo que
Yes.
posiblemente puedo interpretar algunas de las inquietudes de quienes nos están escuchando. Porque otra dificultad fuera del riesgo de aspiración y de intubación fallida que corre la paciente, existe el riesgo del recién nacido, del feto, que puede estar expuesto a un grado de depresión del sistema nervioso central debido a las drogas de inducción anestésica. Creo que ese aspecto es también muy relevante y te quería preguntar cuál es tu opinión acerca del momento para la administración y la secuencia de administración de drogas para la inducción y intubación antes de la extracción del feto, antes de la cesárea. ¿Cómo lo haces tú?
Yeah. Yes. Good question. Thank you for asking the question. Like you may have noticed during the presentation, I used only the name of 2 drugs. So as a routine for the very uncommon general anesthetic for cesarean delivery, meaning our incidence of general anesthesia for cesarean delivery is very low. But in that situation, whenever it occurs, if I am doing it, if the patient is hemodynamically stable, I use propofol for induction. And if there is no contraindication to succinylcholine use, I use succinylcholine. 2 drugs, nothing else, before induction of anesthesia. Majority of these cases are urgent emergency stat situation. So the babies are delivered very quickly, within 1 minute, 2 minutes, 3 minutes, 4 minutes, something like that. Early delivery of the baby. So exposure of the baby is to 2 IV medications, propofol and succinylcholine, and I put them on volatile agent like sevoflurane at less than 1 MAC, but I use a little bit of nitrous oxide and a lot of oxygen. Nitrous oxide only if patient's saturation has been reasonable. Otherwise, it's oxygen 100% and sevoflurane. So the exposure is limited till delivery. As soon as the baby is delivered, the umbilical cord is clamped, then I will give some midazolam, some fentanyl, and some additional drugs that are needed, oxytocin, add some more nitrous oxide, go down further on the volatile agent, because high dose volatile agent can cause uterine relaxation and uterine atony, and it can cause more postpartum hemorrhage. So some use of sevoflurane or volatile agent that is available, preferably 0.7 MAC or less, but limit the number of IV drugs till the baby has been delivered. Does that answer your question?
Totalmente. Y una cosa adicional que posiblemente también sea duda para muchas personas. ¿Intubas a la paciente antes o después de sacado el feto, sacado el recién nacido, de la extracción del recién nacido? ¿Antes o después?
Are you asking the audience?
No, a ti, Ashu. Quiero que me digas tu
Yeah.
opinión.
Always
¿Intubas
before.
antes o después de la cesárea, de la extracción del recién nacido?
So pre-oxygenate as much as you can, rapid sequence propofol sucks, intubate, then tell the obstetricians to cut. So the obstetricians don't start till we tell them, and I will always intubate And so far, with God's grace, I've never failed. I've been doing this for close to 40 years now.
Muy bien. Súper, muchas gracias. Doctor Juan Carlos Mandujano quiere hacer un comentario desde México, Ashu.
Yes.
Adelante, Juan Carlos.
Muchas gracias, Ricardo. Yo solamente trabajé 26 años en un hospital de obstetricia, el cual más o menos manejábamos alrededor de 6,000 a 10,000 procedimientos en obstetricia, de partos, pregrados, cesáreas de urgencia. Me parece que es uno de los temas más apasionantes e interesantes, sobre todo porque siempre está el compromiso de manejar al binomio. La realidad en distintos países es que en México, por ejemplo, se ha establecido algo de que sí, como médicos anestesiólogos tenemos la prioridad de darle la opción a los dos. Sin embargo, en el marco legal ya en México, la prioridad para nosotros es completamente preservar la vida y la integridad de la mamá. Entonces, lo que nosotros hacíamos mucho en México, yo me acostumbré a que siempre tenía la paciente con posición de rampa. Es difícil porque para el ginecobstetra no siempre le resulta fácil operar. Y entonces tuvimos que acostumbrarlo a que ellos operaran con cierto grado de posición de rampa, lo que el doctor Ashutosh mencionaba. No tocan a la paciente hasta que nosotros no les decimos que la pueden tocar. Hay algunos que están tan desesperados por querer sacar al bebé que están ya con el bisturí en mano como si fuera cuchillo y para cortar. Entonces, siempre es tratar de asegurar la vía aérea del paciente. Y lo que yo les decía es, espérame 40 segundos. Yo sé que en la actualidad es mucho el manejo de reporonio, sin embargo, nosotros utilizábamos en este tiempo de manejar obstetricia, utilicé yo mucho la técnica de precuarización. Entonces, yo precuarizaba con becuronio, tenía la gran ventaja de que podía contar con succinilcolina. Entonces, ya al momento de preparar todo, campos vestidos, neonatólogo presente, todo, yo hacía la inducción solamente con propofol, sí manejaba la dosis de fentanilo, la dosis que le correspondía mínimo 200 microgramos para la cesárea. Pasábamos la succinilcolina y era, espérame, 30 segundos. Cuando contábamos con videolaringoscopia era videolaringoscopio, sino la pala de laringoscopia que a mí me ha sacado de muchos apuros ha sido la pala de inducción Macintosh Folio. La facilidad que tiene para poder introducirse es preciosa y siempre contaba con un buggy. Entonces era, si no podía desplazar el tubo, desplazaba el buggy y ya era la situación de inicia la cirugía y en los que ellos comenzaban a abrir, nosotros ya estábamos pasando el tubo. Habitualmente, salvo los pacientes que ya llevaba el bebé bradicardia fetal, la gran mayoría salía sin afectación sobre el producto. Entonces, es apasionante la anestesia en obstetricia, es una práctica excelente. Yo comentaba al principio, por ahí me parece que fue en el 2016 en la revista de la India, una revista de India, salió un algoritmo muy parecido o basado en el algoritmo maestro del DAS. Es muy práctico, está buenísimo, porque incluso hablan ya de la parte del abordaje de la paciente para cesárea perimortem y de todo lo que tenemos que hacer y mantener tratar de mantener la oxigenación, como decía el doctor, para dar oportunidad al producto. Entonces, es una excelente plática y muchas felicidades, como siempre también a ustedes, Ricardo, un excelentes temas los que se dan y pues muchas gracias.
Muchas gracias,
Thank you.
Juan Carlos. Ashu, ¿quisieras agregar algo?
No, I'm available if anybody has a question.
Parece que no. Ya estamos en el momento de terminar el webinario, así que quiero darte las gracias,
Okay.
Ashu, por tu disponibilidad, por la fantástica entrega que has hecho hoy día de tu experiencia. Y quisiéramos, en nombre de la universidad, tal como dijo el doctor Latrop, darte las gracias por tu participación y que ya reconoceremos.
You're welcome. Thank you for having me.
Quisiera compartir pantalla para para presentarles.
Voy a poner algo para que te sientas más.
Should I exit?
¿Sale?
Para decirles que nuestro webinario está en las redes sociales. Tenemos más de 1.100 seguidores actualmente, tanto en Facebook. Tenemos este canal de YouTube, donde están todas las grabaciones de estos webinarios. Acceder a ello a través de código QR. Estamos también en Instagram y en X actualmente.
Oh,
Quiero
wow.
invitarlos a participar en el próximo webinario el sábado 26 de octubre, donde nuestro doctor Sergio Quesada, profesor del programa de anestesiología, nos va a hablar de un muy importante tema acerca del manejo de la vía aérea en cirugía torácica. Él es médico
What
del
surgery?
cirugía torácica.
Thoracic surgery.
Él es profesor de uno de nuestros campos clínicos del programa de anestesiología de la Universidad Diego Portales y tiene una gran experiencia en el manejo de este tipo de técnicas. Así que, por favor, reserven sus agendas para el sábado 26 de octubre para no perderse este fantástico nuevo webinario. Muchísimas gracias a todos. Ha sido un privilegio poder tener al doctor Wali desde Houston, Texas. Así que nos sentimos muy satisfechos por esta jornada cumplida. Muchas gracias, Ashu. Muchas gracias, doctor Latrop. Muchas gracias, Gabriela. Y muchas gracias al equipo de traducciones remotas que, como siempre, nos han ayudado de manera muy importante para que estos webinarios con expertos internacionales puedan realizarse.
Muchas gracias, Ricardo, y nuevamente un placer, doctor Wali, que esté muy bien y que tenga un lindo fin de semana. Muchas gracias de parte de la universidad.
Thank you. Thank you.
Gracias, chao, chao.